Before we start, we're just going to ask you a few questions. There is no abstaining, it is not Brexit. You must give an opinion one way or another. And it's just go with your gut first instinct. Don't overthink this. And after these questions start, I'll ask the questions again at the end, if that's okay. So full joining in, please. So, who holds the bulk of the risk of an old patient, frail old patient with a falls risk is discharged from the hospital ward or the emergency department? So the paramedics, I suppose, left at home rather than brought into hospital. Is it all the clinician, most of the clinician, about equal, most of the patient, or all patient? So shows of hands, please. Don't look around the room because everyone does it and goes, but you stick your hand up here. So, all clinician. Mostly clinician. Equal. 2/3. Mostly patient. All patient. Cool. Okay. Excellent. Thank you. Second one. I'm accountable for my decision and the actions and the outcomes of that decision when talking about an individual patient. When I make that decision for that patient, is it just the effect on that patient, the effect on that patient and those under my care, for all those on my ward or area, for all those on other wards, or for all those in and around the hospital as well? So, hands for just that patient.
So I don't really understand what you're asking.
So, okay, apologies, not very well. So, if you make a decision about a patient, are you just accountable for that, the outcomes of that decision on just that patient, or that patient and the people around them, that patient and the people within your ward or area, that patient? So every decision we make has a consequence. So is it just that patient you have to think about, or is it the effects on other patients and the rest of the system as part of it? Does that make sense? Sorry. What do you ask? So just that patient. 1, 2, okay. That patient and those under my care. A few more, 4 or 5. Those on my ward or area. Those in other wards. And those in the whole system around the hospital. About 6 or 7. There's definitely some abstainers. Okay. Thank you. So, this is how we see risk and safety is really important. I think this is brilliant. So, Alex, I'm going to challenge your preconceptions a little bit. So several times people have said today, they need to be safe, or the decision is safe or not safe. I don't believe you can have safe. We talk about healthcare all the time. You can have safety and safer. What is safe? Safe means no risk. What part of life? Can you give me an example of something in life that has no risk attached to it? There is riskier and less risky. There is safer and less safely. We come here, it's not safe, they can't go home. That means staying in hospital has no risk at all. We use that. It's not safe to leave them at home, they might fall. That implies that bringing them to hospital has no risk, or that I want to send you home. All those things, there is no such thing as safe. And please feel free, if someone give me an example of something that is completely in every way safe, has no risk in life. Yeah, so that's not something we aspire to. But so in life, is there anything that gets we will say it all the time, it's not safe. They can't. It's a great blocker in healthcare. It's a great blocker to stop people. People are like, not safe on the stairs, not safe to go home, not safe for this. We write it in ours all the time. I don't think that, I challenge you to say, does that actually exist, the concept of safe? Is it risky, it's low risk, medium risk, and actually, if you look at elective care, it's all about balancing risk. You inform a patient of the risk, and they then make their choice. That's what we do in elective care, we're negligent if we don't. So why in urgent care don't we do that? So things we see that cause harm across the system, and behaviours we see. So we see people get admitted to the hospital who don't need admitting. Probably puts that patient at risk, because the hospital's got a building full of infections and concrete floors and deconditioning. But it also puts someone else at risk. They go to the hospital, they take a bed, someone else sits in the trolley in ED, or someone else gets outlined. Both of those things increase your mortality. So we're probably putting 2 people at risk by admitting someone who doesn't need admitting. Delayed discharge is exactly the same. We're putting them at risk by keeping them in, they're probably deconditioning, and we put someone else at risk who didn't get that bed. Language is really important. So home and blood's normal. You see that written hospital notes loads of times. And why does it have to be normal? Why does the patient have to be normal before they go home? When we write it, we know what we mean when we write that. If you write that, the junior doctor on the wall will follow that. They're not normal that. The surgeon's 134, not 135, they can't go home. Well, they'll wait for someone to say they can. So what is an acceptable limit? Reassurogram, anyone know what that is? It's a test we do to make the clinician feel better. So we do I'll just do a chest x-ray just to check they've not got pneumonia. Do you think you've got pneumonia? No. You can't go home with another chest x-ray tomorrow to check it's got better. We know pneumonia takes a while to resolve on chest x-rays, but we still do an x-ray just to check it's not got worse, even if the clinician's got better. And we see it a lot, just check bloods. Just do a CT head, just in case they've got a subdural. Any evidence for that? No. Keeps people in hospital, displays things. Refuse to work in a different way. I don't like doing a hot week working. I want to do my ward round twice a week. That may cause delayed discharges, which we know causes harm. That's the evidence would be it's better to do. Wards, refuse to board a patient to sit out or use the discharge lounge because it might cause a complaint. Or a patient complaining because they're in the discharge lounge is better than the patient complaining who sat in the trolley in ED, or even more importantly, better than the patient complaining who sat in the community waiting for the ambulance to get to them because the ambulance is stuck in the hospital because they can't offload. We talk a lot about what we see in front of our patients. And this is good people doing the right thing for patients, what they believe is the right thing for patients. Ultimately, we know it's doing harm in the back of our heads, but it's really hard to accept that. EDs won't offload ambulances. The OTPT reflex, have you heard of that?
Yep.
What's that?
Refer OTPT.
Yeah, so medics do it usually. OTPT don't know. And you go, well, why? If I refer to a cardiologist, I'm saying, why am I referring to the cardiologist? Because somebody is old, why do they have to see a therapist? Simple question. Have you had a fall? Can you walk around? Have they walked on the ward? Yes. Do you want to go home? Yes. Why does that need a new therapy report? We see it time and time and time again. And do you ask the junior doctors why they write it? They say, well, I'm EMDT approach. And you go, why? That's not what you've written. If you write OTPT, most ward nurses won't mobilise that patient until the therapist said they are safe, in inverted commas, to walk. And you ask them to why. Well, if they fall, I haven't seen the therapist, it's my fault. So someone writing OTPT in the notes can mean someone stays in bed for 4 days over the weekend. We'll talk about that in a minute. But all these things are well-meaning things, and they don't mean that, but the consequence of what we do and how we write in state is really important. Language, again, so I'm not happy for you to go home. How does that feel?
Terrible.
Terrible, yeah. Who am I talking about? I'm not happy for you to go home. Yeah, I'm talking about what I'm happy for, and we see that clinicians, and I've done it myself, and I hear my colleagues doing it, and I try and challenge them now. I'm not happy for you, I'm not happy to sign them off on the stairs. The clinician, the therapist, the nurse, whoever is doing it, I'm not happy to leave them at home. I've heard crews say that to them. You talk about your own happiness. We don't come to work to make ourselves happy, we like to. Our job is to make patients. Give them the choice and let them do what they want to do. But that language is always how we hear. But you might fall. When Bharath and I gave this talk last year, and he arrived very late, so I sat in the bar for 5 hours waiting for him the night before to plan the talk. And I tripped up the stairs walking in the hotel. So we're all a falls risk. Even if it's stupid like me. But we're all a falls risk, and actually, you might fall is inevitable. So that's not a reason for someone not to go home. It's not a reason to get someone out, not to get out of bed. Everyone is a falls risk. You will definitely decondition in bed. You might fall if you stand up. There's a definite and a might there. And then I'm not risking my pin, we hear quite a lot, quite commonly across the system. You only risk your pin if you do the wrong thing for patients and don't document it. Not the right, or do the right thing, don't document it. You cannot lose your pin for doing the right thing, so long as you've documented it. All the court of law wants you to do, and I've checked this with the Medical Defenders Union, Medical Protection Society, trust solicitors, and everyone will say, yes, you cannot be prosecuted as long as you have documented appropriately in the notes. And I've asked, has anyone been prosecuted in the UK as a medic, and I've asked about nurses or therapists, for discharging someone if they've documented it correctly in the notes? And the answer is nobody. Not one successful prosecution case. And they cannot sue you, they're afraid of being sued, they cannot sue you as an individual because you are covered by your organisation, unless you do something ludicrously stupid like take someone's brain out. You break every rule in the thing. You cannot be sued, but everyone you ask them, they're scared of being sued. You cannot be sued as an individual successfully. And the relative might complain is another common thing.
I might.
We see that. Right now, I know in my own hospital, there are people in the hospital who haven't gone home, but the relatives might complain they've been discharged early, knowing at the time there are people stuck in ED and ambulance trolley. That's the complaint you want. The answer is you can communicate well with the relative. Actually, I'm telling this because they're fit to go home, and that we haven't told them the risk of staying in. That's why they're complaining. We haven't actually talked about the risk that's hidden, the risk of being in hospital. We talk about the risk of going home. We don't talk about we're in a building full of infections with concrete floors, and every day they stay here, they're losing muscle mass and confidence. Would you like to stay in hospital if they're fit to go home? Why do we do this? People believe responsible for my patients and that sort of thing. So some hands there, I'm only responsible for that patient. I'm not responsible for ED or ambulances. Well, we're all accountable in society for all of our actions. We recycle to do the right thing for society. We drive cars with catalytic converters to do the right thing for society. We always enjoy it. Might be suing currency, might be called for the coroner. Really unlikely. Our hospital admits seeing 140,000 people through its ED, admits 30,000 people a year. Coroner's cases a year, 20. Number of times trust solicitors had a consultant actually actively in trouble, seriously in trouble as a coroner, twice in 20 years. 30,000 admissions. So you ask people, they're all scared of the coroner. What if I get to the coroner's court? The odds of this happening are so low, it's ludicrous. We still, it's naturally human nature to worry about this stuff. It's not my job. Comments like I can't see the people at the front door in the community, but I can see the patient in front of me. We know they're there. And the stuff that we measure, and as Liz mentioned it earlier a little bit, if you measure falls and infection control rates, is that going to promote a positive mobilising culture in your wards? And we call a fall a serious incident, and there's a load of paperwork attached to it. What's the best thing to avoid that? Keep the patient in a chair. Even though we know if you measure falls and mobilisation rates, a balancing measure when you measure these things, this is how we change culture. People will do ward metrics, people are terrified of their ward metrics, whatever. If you measure falls rates and mobilisation rates, you're much more likely to get a measured outcome. And if you mobilise people every day, you have a lower falls rate because they don't decondition. But we're so scared of falls. One of our wards said, we've had 0 falls for 120 days. We're not mobilising people properly, that's the answer. Really not. And we're proud of it. And that's the answer. You cannot be. Anyway, that's how we do this. Hand over to Bharath now, who's the far smarter looking colleague.
I gotta try harder than him. There's no political affiliation. Couldn't get enough of that at home already. Luckily, Colchester's blue as well. I'm turning that right. So, under community geriatrics, I've been doing it for a while. And then it became my passion. And then one of the few things is we rarely get slides which we can talk to people, which is related to patients. And once you get them in, we're all doing the right thing. The patient's not safe to go home. I mean, most of the questions was asked by Ben, and you have all the answers. But when you look at it, Clegg came up with a really interesting slide over here. This was in 2003. Functional abilities of the patients getting into hospital and what happens to them. Most of the people are living outside. See the GP, see the paramedics, they get the PGD, chest infections, falls. They get given steady strips done in residential and nursing homes, and everything's okay. If you're in the less frail group, which is less than 85 plus or so, you get back to normal pretty quick. We did the right thing. Okay, this patient could have gone on, might have gone on. But once we put them in the hospital, we got a few things going on. This was an interesting study which we found. It was done around about 12 years ago, and it's been correlated again and again. When we look at the activity levels of patients who are 80 plus, and barometric studies were done, 83% of their time was spent horizontal. Then becoming deconditioned is a no-brainer. We then find out we need to do something for them. We all work together, and then finally we may get them up there. So how do we look at this in the current studies is, if this was also an interesting study when they looked at 10 days bed rest for healthy elders. I mean, in America they call them healthy elders. Anybody above 55, 65, 75 called elders. They're not called seniors, they're not called. So what they did was, interestingly, they put them around about 65 is the maximum age. They did quite a few things to these patients. They put them in bed, made sure they didn't get VT or thromboembolism, did blood tests, and then they measured their activity after 10 days of pure bed rest. What they found was they lost nearly 12% of the aerobic activity, that is VO2, maximum oxygen consumption. What also they did was they looked at how they can get up and down stairs, knee and hip power. They found that it was reduced by 12 to 15%. Now we're talking about somebody 83% of the time are horizontal in bed in the 85 plus. Its majority of your patients staying more than 7 to 14 days will be 80 plus, and they've got other comorbidities. The other thing is they also looked at, okay, we keep them in safe, we're doing the right thing, and then we don't do much for them, and they looked at how they come out of hospital. They need at least a 50 to 75% increase in their ideal health. That is packages of care which we see in the social and healthcare system. That means around about nearly 20% also can go into residential nursing homes. And if they've stayed in ED longer, then the mortality is also high. So if you have commission care packages in the community and we're still not fixing the flow, or looking at patients why they need to be there, we're never going to catch up with that activity. The other thing was, this was a simple study. Clark in Scotland looked at all patients who were admitted, and then a year later he went to the registry office and said, can I have the death certificates of all the people who were admitted in Scotland? What they found was 48% of 80 plus had died. So we're not talking of simple numbers, we're talking of big numbers. But there's no point talking about it unless you feel how the patient feels. If everybody's ready, we can do a small exercise. Everybody ready for the exercise? Get your chairs free. Then hopefully you can see me over here. So everybody give yourself some room to stand up from the chairs. Just give it a try, see how it feels. Easy peasy. So somebody's in bed most of the time, length of stay 7 to 10 days. So have a seat back now. And then make sure your heels are in line with your knees. Your heels are in line with your knees. And slightly ahead of the chair. Then try to get up again from the chair. That's somebody in bed for 10 days. This is a proxy measure, something we need to do to feel. But now just feel somebody's been there for detox. So put your feet well ahead of, and then make sure the knees and heel are in line. And then try to get up from the chair now. Do you want to do it again? But no, 83% of the time you're in bed, right? So if you want to do it again, just have a feel out how much energy it takes. Okay, well ahead, in line, and you can stand up again. So it's a proxy measure. And then this is how a patient feels. They came in completely independent. We did everything right. We did everything for their safety. And then also we try to do the rest for them to get them home. But there are lots of things which we need to put into place in our own thinking and embracing risk to make sure that we're doing the right thing for them. It's Ben's turn now, sorry.
With that chair test, I would encourage you to do that. I've done that with our trust board and all our duty doctors, and it's absolutely vital. And the point I made to them as well is that feels hard for us, and all of us could juggle a flight of stairs or walk a few miles, whatever it is, and some more than that. Imagine your normal is walking with a frame across the room, and then you sit down for a rest. You take from that to how we felt there, they're now bed-bound and lost their independence. So we are independent, fit adults. We're not the people we're talking about here. So that's the part. That test is different between living in your own home and not living in your own home. And that's the message that has to go across to people. That's the Bible. So this is a bit about managing risk and avoiding deconditioning. In elective care, we can learn a lot in acute care from elective care. Much as a person who works in ED and manages acute medical care, we can learn a lot from the surgeons. Not everyone who has their hip replaced goes home as lucky as they're discharged date. There's a variation in it, but they're fairly predictable. And actually, in doing so, you go, right, you're going home on day 3 or day 2 or whatever it is, depending on the patient. You get therapy lined up to manage that, your family's lined up to manage that, your home already. We'll make sure you've got your frame, whatever you need in place for that, and you'll go home on that day. And every day we're going to mobilise you because you don't push hip replacement or we're really good at elective care. And actually, surprise, surprise, most people go home in or around that date. In urgent care, we're not so great on ED here. We go, I can't really predict it, it might be wrong. Doesn't matter if it's wrong. It matters that you're working towards a date to get them home. If patients know they're going home on a given day and their relative goes, "We'll work all day, I can't pick them up, let's make it the day after." That's one extra month to stay, just because we didn't tell the relatives they'll be going home that day. It's really common hospital to tell them the day of discharge, "I'm working, I'm away that night, I can't help them." Telling them now it's not rocket science. Starting therapy on day one, not when they are medically fit or whatever else, will help them get home quicker if they need therapy or if they're going to need a framework. We don't change. If they go past it, it's working out why they've gone past it. Okay, we don't do this. Elective care, we do it every time. Emergency care, we don't do it. It works in elective care, why don't we do it in emergency care? Plan for discharge at the point of admission. It's pretty obvious what most people need. I ask them what they want, but it's really important. We don't do that. Same slide, we'll do that. One thing about this, they only don't fear death, they fear loss of independence. We're worried about them falling or injuring themselves and them dying. You talk to most old people, they're scared of going to a nursing home, and they're scared of not living in their own home or doing their own thing, and they hate it when they can stop driving, they hate it when they can't go to the shop, they hate it when they can't go to the pub, whatever they do. They're scared of loss of independence. Death is inevitable when you're old. They all know they're going to die. What they're worried about is loss of life before they die. And we're worried about that. So what matters to me is so important for the patients. And the way we've got risky life, and people will do things and change that. In healthcare, we're really good at changing policy. So we had a patient, they got out of bed, they walked on the ward and they fell. Well, we'll change the policy. No one walks until they're a therapist. That's when also no one old and frail will walk. And actually, there's harm in all that. In life, we don't do that. We drive these metal boxes down the motorway at 70, 80, 90, whatever miles an hour we choose to drive at. Some people will eating an apple, do whatever they do, I'm with you or half in the car. We do that. That's a risky thing to do. Even more risky, driving an A road home. Some people will die today in their car in the UK, driving their car. They do not get in their car, they don't think twice about getting in their car. We know that's a risk. We fully accept it. But there's a crash on the M1 last year when 9 people died. There you go, right. M1 today, everyone drives at 20 miles an hour, and they'll all wear a helmet and a fireproof suit, and then you can drive. Everyone just got in the car and drove down the road. We accept there's some risk in driving cars, and airbags and the normal anti-lock brakes and that sort of thing are acceptable ways of driving a car. We accept some cars will crash, we accept that some people will die. We try to minimise that, but we don't change the speed limit on motorways when people die. That's how we approach risky in life. We get on planes, when planes crash, we still get on them. We don't compromise that. And actually, in healthcare, we tend to go, we'll stop that ever happening again. I worked with a hospital where someone with a high potassium left ED, went to a ward, someone didn't check the potassium, they went high and they died. The response to that was not to say, we need to make sure everyone resets potassium. They said, no one will ever leave ED resus with a high potassium again. And the harm of that is that ED resus backs up. And everyone's going to offload it. We try and avoid, we change a policy after one event, really commonly in healthcare. And actually, what was the risk of that and how we approach and manage risk. All we're really doing when we do that potassium example is we create significantly more risk in the ED or in the community. We've made more risk out of a situation by responding and for doing the right things. These are real risks for patients. We don't talk about these to our patients. If you're a risk of a crowded ED, you have 43% mortality increase if you're a long-stay patient. There's a later one that's coming out almost immediately, very soon. Then if you're admitted to a crowded ED, the number needed to treat to get one extra death. If you spend more, for every person that spends 8 hours in an ED before they leave the ED, every 34 patients, one extra person will die compared to if they left the ED in 4 hours. If that was a drug, we'd be banging on our table saying, I want that for my patients. That's the reality of delays in ED and decommission. Last time David talked about it, how many of those days would you spend in hospital? We'll talk about in a minute. And the muscle mass loss, so 10 to 20% of muscle mass loss per week. So you can take an independent person into a dependent proper person. And that means that person may never go home again. Some people die in hospital of pneumonia. Actually, some of them could have gone home. We know this happened. We cannot joke about it's really serious. You may never go home again if we get you in hospital. There's a risk of that. That's informed consent. You could go home. You might fall at home. Go to the hospital, you might have less chance of falling. If you do fall, you're more likely to break your hip. These are real risks, and we don't talk about this to patients. We don't talk about hospital risk. We talk about the risk of going home. We do not talk about the risk of hospitalisation. It's uncomfortable for us to do it. It's real. If we're in elective care, we're negligent if we don't consent to an operation that way. Which is why I don't do it in elective care. Back about the money thing. The single most expensive thing to do with the patients is put them in an ambulance and send them to hospital. I've already said it. Hospitals, buildings full of ill people and admitting them admitting increases the risk to each patient and to other patients because they don't need it. We talked about that earlier as well. Logically then, for a system, we're here in a healthcare system, the only sensible thing to do for those that are not unstable, so hypotensive, hypoxic, whatever else it might be, to be treated at home, or high risk of serious harm, so people have just had a heart attack, they may be stable, but we don't want to discharge them the first 24 hours after a heart attack because of the high risk of death, should be treated in hospital. Everyone else, for cost and risk management, logically, surely should be treated somewhere else. Because otherwise, we're putting them at risk and it's costing more money. But that is what our current system does. Because of the way we manage the finance and risk and we don't cross our boundaries. So that's the challenge about people today about how we think about things, how when you have new discussions, they don't want to disagree with our logic. No one disagrees on why we're doing it. We can change this if we choose to. To hammer home the point about the 1,000 days, this is a nice hotel room somewhere in the world. You go on a nice holiday, we all go on a nice holiday, you go on a nice holiday for a week, and actually come home, how good does it feel to get into your own bed? Nice to get in your own house, nice to get in your own bed. A great holiday, but nice to be home. Right, we're going to TripAdvisor the hospital. So most people, average length of stay is more than a week in hospital. Accommodation. I share a room with 4 people I don't know. Sometimes one shouts out in the night, wakes me up. I don't know where I'm going to wake up. How many stars? Minus stars, 1, none. Yeah, okay. Food. They send me food I didn't really want. At the time I didn't want it. Sometimes stuff in a plastic tray. Sometimes it's lukewarm. I don't really get to choose. I get to choose a bit, but not really. And I can't have a beer, I can't have a glass of wine, I can't have a... Stars? Any more than 1? Bathroom facilities. I had to poo on a cardboard tray behind a curtain with the entire bay listening to me while I did it. How many minus stars? So we're laughing about it. But some people spend 3 months in hospital, and that might be their last 3 months of their life. So how many days would you choose to spend in the 0-star TripAdvisor hotel? Any time. Never mind when you've got 1,000 days left to live. However, we're all very proud of our hospital, right? This is my hospital, which is the most artfully taken photo in the world. It's not by the Mediterranean. It's in Mansfield, in Nottinghamshire. We talk about very proud of how good the hospital is. Excuse my language, it's shit being a patient in hospital if you're well and need to go home. However nice we make it, it's really crap compared to being in your own environment. We're very proud of our hospital, and I think we're hopefully rightly so, but actually in reality we're proud of giving someone fairly naff life experience. It's good care, but it's naff life experience. That's the nominated life. So that's the reality of what we're doing to people. We can change that, but if we start to see it like that, and we talk to our staff about it like that, then actually, well, we have great patient satisfaction scores. Yeah, but they don't know that they could be at home or could be somewhere else. If we talk to our staff about that, actually, we might change mentality, we might shift them, we might move some people out, we might not have people queuing in EDs or coming to hospitals. But until we have that honest conversation, we're not going to change that. Elective care, we talked about that, the consent thing I briefly touch on. To show you how silly this is, if someone goes in hospital, a frail old person in their 70s, needing a bypass, they can't manage it, need a bypass, it's a big operation with a high mortality, but if they don't have it, actually, they're likely to develop heart failure and deteriorate and die if they've got severe coronary arteries or happens with sudden cardiac arrest. The surgeon has to consent them. These are the pros of having the operation, these are the cons of having it. These are the pros of not having it, and the cons of not having it. Wound infection, hospital day, dying on the table versus dying on deconditioning, function afterwards. If they don't do that, they are negligent. They do the operation anyway, so we feel it's the right thing to do for the patient. They could be struck off the DMC register for being negligent if we don't consent. Anyone disagree with that? If you don't consent to an operation, something happens, or you don't do the operation, you can be struck off or certainly disciplined or whatever. The same patient can be readmitted to hospital 10 days later with a hospital-acquired infection, chest infection, onto a medical ward, for example. Be in that hospital, having had a major surgery, then having a chest infection. We'll be quite weak at this point. And then someone could write in the notes, not safe on the stairs, unfit for discharge. So you consent for the life-changing, serious operation with negative we don't consent, and then they don't let them decide whether they want to climb the stairs or not. Same patient within 2 weeks. Climbing the stairs, very basic thing. They can choose to climb the stairs in a dangerous way. When I carry my kids upstairs or my dog or whatever else, that's probably a risky way of doing it. I'm allowed to do that. We don't. Why do we write not safe or we're not consent? This question for you. I don't know why we don't do it. We become paternalistic about elective stuff, emergency stuff. Elective care, we're very good at consenting. We did that for emergency care. I bet we have far fewer people in hospital. Prolonged stay, increased risk of chest infection, increased risk of wound infection, increased risk of hemorrhage, increased risk of all those things. Which one are you going to have? Anyone for this one?
Well, I'd be annoyed if I had that sort of scarf.
Exactly, yeah. Things to be worried about, isn't it? So, this is which one is easier for the surgeon? This one or this one? That's easier for the surgeon, has worse outcomes for patients in every single way. If a surgeon was doing this and not that, someone would challenge them and stop them. First point, crap for patients, easier for the surgeon, much better for patients, more friendly for the surgeon. So why, if someone was doing a really poor way of managing their ward or their borderlands or admissions, you go, that's just how Dr. So-and-so does it. We know there is harm from long length of stay in hospital. We know there is harm for not doing that. We find these conversations really uncomfortable. But we're very keen to do it when there's a procedural thing. Bless you. It's hard to do it's really hard to do when it's a way I work kind of thing. But we know they're both harmful. For one of them, we find we'll happily challenge this. Just a question for you: if we start to speak of and challenge behaviours for all things that are harmful to patients, we can do it in a pleasant and polite way, in an engaging way. We might start to change behaviour. People aren't doing these things to cause harm. They're doing things they don't see the benefit or they don't see the risk. As soon as we start to talk about risk really openly in our hospitals and our communities, we won't change the behaviour. So my question is, go out and talk about this stuff, please. So language we can change language we use. I'm risk averse, you're probably just shifting the risk somewhere else. My risk, that sort of thing. Back to baseline is a phrase that's commonly used. Everyone see back to baseline? So I had my knee operated on 4 years ago for a cartilage. I'm not back to baseline. I can't run down the hill because my knee swells up and causes me pain. You could argue I should still be in hospital. I'm not back to baseline. Back to baseline is a ludicrous phrase to put on someone. Put you in a building, you've been ill, feed you food you don't want, keep you in bed for 10 hours, for 18 hours a day. You walk 50 steps a day. Am I likely to ever get back to my baseline in that scenario? Fit for discharge is very different to back to baseline. If you write back to baseline the notes, the staff will try to achieve back to baseline. Please don't ever write. If someone writes it, say, why are you expecting back to baseline? They've just been ill. It might take them 3 months to be back to baseline. So if we don't challenge this language, people will do it. Medically fit for discharge, we sometimes see this, social care people saying things, they're still on antibiotics, they're not fit for discharge yet. Fit enough to go home, they don't have to be fit as in better, they should be well enough to go home. Medically fit is different to medically optimised or well enough to go home. So I would definitely not safe to go home and talk about failed physio. Imagine being a patient, I'm going to pick on now. You've just failed your stairs assessment, you're a failure. You cannot go home. How does that feel?
Yeah, you give up.
You give up, yeah. We say it, I've heard my colleagues say it to patients, we've just failed physio, admit them. Have you asked them? No. Have you? No. And they've actually said failed in front of the patient. Really powerful. When you're a patient, you're vulnerable, so they say, I'm not a silent laugh, I'm here for my patients, that sort of thing. So, there's risk in whatever we do, there's risk in all the outcomes for our decisions. Interestingly, we want autonomy for ourselves, we all want that, but safety for our family, as relatives, or safety for our patients. And risk aversion often displaces the risk, and actually we're arguing the risk belongs to the patient. If you do your job properly, there is no risk to you. It's about balancing risk. There is no safe or no risk, just safer or lower risk, and that's what we have to talk about, how we do it, and that risk may change depending on the patient and the situation. Every decision we make about a patient has a risk to them, but also a direct effect on another patient in the system. that extra test, that extra ambition, that delay in discharge probably harms someone else. And examples in real life, you took littering. Who drops litter? No, I wasn't willing to admit it. No. Someone once said, why? Why don't we not drop litter? Someone went, I might get fined. At least they were honest and said, I might get fined. But actually, we don't drop litter, we recycle, we make sure carpet because it's the right thing to do. You don't throw a can of Coke out your window in the car and drive off and go, it's not my garden, I can't see it. We know it's there, but we do it with patients in hospitals, or patients in ED, patients in... So we know it's happening all the time. So there's a phrase that's important. Two phrases that are important here. First one, the true test of a man's character is what he does when no one's watching. So absolutely, what we do in life, not when we're being monitored, not when we're being tested massed, it's what we do when no one watches. It's really important. And we have kids. I've got my kids, I try to say to my kids all the time, do the right thing, even if it's hard. It's hard to do some of this stuff, it's hard to do the right thing, it's hard. But for those that still do it, that's the second message there. But there we go. So, how do we change this? Encourage the staff to change the language they use, the approach to decision making, the concept of risk and who owns it. We have to talk about this to our staff and our patients. Give the patient the information, give them the choice, give them the risk, and ask them what they want, because that's our job. And actually, I made this switch to clinician a few years ago, and it's actually quite liberating. Once you realise the patient holds the risk, you have to talk to them about it, it feels much better, because you feel less responsible and less scared. Really hard to do. Once you do it, it feels so much better. And I encourage you to talk to your staff about it, because it won't change until we talk about it. Really important. So we can do things differently on the wards. I'm not going to do details of this. It's basically about in urgent care, discharging the patient is so much more important. Palliative care, we'll talk about in a minute. Discharge patients. Don't worry about their news score. Look at the patient. How are they? Really important thing for patients. 4 questions. Dead simple. Should everyone in hospital know this? The answer is yes. Do I know what's wrong with me or what's been excluded? Very reasonable. What's going to happen now today, tomorrow to get me sorted out? What do I as a patient need to achieve to go home? If I know I'm going to walk to the toilet and back to go home, I'll probably try and walk to the toilet back every day. If you don't tell me that, 4 days in, right, can't go home, you're not get out of bed for a week. There's no opportunity then for them to do that. They could have been working on that from day one. And that's the EDD bit. If my recovery is idea, when should I go home? So the family help can get ready for that. Very reasonable. How often did that happen? If you ask, go around your ward, ask your recruiters, ask the patient those questions, see if they can answer them. I bet most can't. You can put this stuff on the wall, you can get your staff to do this. Emergency care is fairly straightforward. Stop them coming if you can, see them quickly if they do. Try and avoid admission and get senior people involved, investigate early. And please plan for discharge. That's how we manage risk in the front door. We'll jump through some of this stuff about plans to stay and things. And basically, admission is not the safer option. It is a risky thing that will decondition them. What to talk about. Patient's time is really precious, and actually make sure we mobilise people as much as we can after discharge. Informed consent for all of the decisions is really important. That we get good at that, we can shorten it. I'm going to pass you back to Bharath. Thank you.
Kind of spot on. We are trying to make the patient safer. The difficulty is, how do you go thinking about it? When you make things simple, everything works. So the patients in A&E, the main focus is to discharge them. Do they need treatment or with or without support? Some patients might need to stay a little bit longer. Fracture, humerus fracture, something else for pain control, a couple of days. That doesn't mean that you need to focus on mainly the pain control. Some of them will have a stroke, fracture neck of femur. They might need a little bit more short-term rehabilitation. The other thing is we've got a lot of patients who are, as they say, self-funding. 10 times a day, patients' family, neighbors, relatives have been helping them out with a 4 times a day or maximum care package, and the patients and family at the end of their tether. There's no point discharging them home. If you have a process where they can go to discharge to assess, or some place where it can be done and not sent home and brought back in, there might be certain advantages for those patients. But when you're trying to make a decision, how do you make it simple? Because the first people looking after the patients or seeing the patient could be the staff nurse or the student nurse, and it could be the SHO or the medical student. How do you go about it? Main things we're looking for is, are they able to eat, drink, wash and sleep at home? Can that be their ideals? Can that be recovered at home? If that's the answer, why do they need to stay in the hospital? If they can do it with, if they can do it with the help of somebody who's there, willing, caregivers, Around about 30% of the patients live alone. 80 plus is a growing population, and most of them are with some carers or family members around, but 30% live alone. The other difficulty is all of us know that when you go to any patient's home and ask them what medications they're taking, they will show you 3 or 4, and then you open the cupboards, there'll be big boxes of refilled medication which they didn't take. That's not uncommon. Nearly 30% do. One of the most common things is if they can take the medications by themselves, they can eat and drink, or they have access to meals, that's good enough. The home environment's safe. It's been safe for 97 years. For the last 98 years, for the last 40 years, the patient's been walking outside to the toilet in the middle of winter. There were worse winters before than now, and they still did that. Yes, they might be frail, but they've not had a fall as such. They might have had a fall now. For 97 years, they did all right. The patient knows the risk, and if he wants to go. But if you're still concerned, then the other thing is if they can go to the primary care, they will be much, much happier. They love going to visit doctors, other people to talk to, and then you're also helping them out in the community. The capacity might be different, but that's one thing which we need to look at. They just been to hospital, just by walking into hospital and they discharge, the risk of falls increases. But there's lots of things you can do. The other thing is if they need some monitoring, it might be that you have services around to monitor their blood pressure, their infections, they need a physiotherapy assessment, occupational therapy assessment to make their home is safe, or if they need social care. There's no point assessing somebody for social care in the hospital bed, and especially at night time as well to see their night needs, because they were okay till they came in yesterday. Today it's going to change? Of course it's going to change. As Liz pointed out earlier, you stay in a hotel room long enough, it will change for us as well. That's only 8 hours at night. That's long enough for us. The other thing is you might say, let's monitor all of them. There's no point in monitoring anybody. The monitoring should be based on a few things. What are you monitoring them for? To decrease risk maybe. The other thing is, are they able to recover at home? And making sure patients are at home. Recovery is quicker and they're more independent at home. When you look at how you assess that, when you look at the comprehensive geriatric assessment which is done, when you look at the reason it's done is to make sure they're independent for the next 12 months. Around about 24% of them stay longer, live longer, and more independent as well if the assessment's done at home. The other thing is, everybody forgets one important thing, early identification of deterioration. They would have done in the hospital, everybody has the news score, national early warning score done, but some kind of monitoring. The patient is the best example. All of your clinicians and the intuition is right. Most of the studies have shown 92% of intuition is right. And if you add Google to clinicians, you're pretty good at 98%. The local population, when they do Google and intuition, they're around about 20%. So we can get help with Google with the extra 6% if you need to as well. The other difficulty is, most of the admissions happen in the first 7 days. So if they are monitored for the first 48 hours, most of the places have commissioned Age UK and other voluntary sectors or some good Samaritans. They give them a phone call, have a chat with them, if necessary, go in and get their couple of eggs or milk or bread, whatever it's commissioned for. Other places are doing that. It seems to be decreasing their readmissions, mainly based on the need of the patient. But one of the things is they do get back to independence quicker. Independence means also cheaper for the patient and the community, but also it gives them a chance to live their life how they want to, the last 1,000 days of life. Everybody knows the E-frailty index. Hopefully primary care has that. When you look at it, and somebody is on the E-frailty index or severe frailty, they got around about 3 years to live, which is around about nearly 1,000 days. So if, as Ben pointed out, TripAdvisor for a hospital, you know where the patients went. One of the examples where we use monitoring is in Northamptonshire. We used to have what's called as a community early warning system, but News 2 came in last year, which included oxygen-related saturation and also the outpour, looking at the patient's consciousness. We used to do that before. This is a no-brainer for us. 2001, most acute illness is basically failure to act on recognized changes. Everybody's waiting for the next person to make that assumption or make that action. That doesn't work. Then the National Patient Safety Agency came up saying that 11% of the deaths are related to deterioration not being recognized or acted upon. They were very, very specific for us to help us out. What did we not do right? Not taking observations, not recognizing early signs of deterioration, not communicating these observations causing concern, and not responding to the concerns appropriately. S-bar, everybody uses the S-bar. The response is from the person on the other side. So if they're asking you for something, if they're calling up a more senior person for advice, our action is to support them to help them out make the right decision. I mean, most of the other places, ambulance services can call consultant connect, GPs can call consultant in the hospitals. There are other ways they do it, and one of the ways was just to make sure. We can use charts which is used exactly like the news chart in the hospital, but it has to be tailored to what the service and the community have agreed. One of the things is the responses are pretty clear over here. The S-bar, and then if somebody has got a variance, and then this is a community sepsis tool as well, which is in the patient's home to help out anybody who's in the community to make sure they action the right things. But we got most of the patients monitored in the community are frail. If they're not frail, we're not commissioning the right services. If they can walk up to a clinic, GP services, ambulatory care, then it's not for community service. But for them, when you look at the data, most of them are nearly about 80 plus. In our county, average age is 85.9. Then the biggest difficulty we face is they all come with decreased mobility. They need some kind of monitoring, some kind of help with the rehabilitation, and also enablement as well. But then we got 30% who live alone. What's the biggest difficulty we see in these frail elderly patients is they have an increased risk of falls. But when you look at the guidelines from the national guidelines for NICE guidelines for frailty, or even if the E-frailty guidelines, it states very simple. Somebody who's moderate or somebody who's in severe frailty needs to have a falls risk assessment at least once a year and polypharmacy review. If you're severely frail, you need some kind of a summary care record or escalation plan. That's what the national guidelines are. But if you have somebody who's about 85 plus, and majority of your caseload or patient population is 85 plus, checking orthostatic is a compulsory measure as a prevention of falls. Also, because somebody stayed in hospital, there's lots of physiological changes which happens, which increases the risk of falls or syncope. If they have a fall, they break something. These are elderly patients. If they break a hip, they die quicker. So there's lots of consequences. All of us are trying to do the right things, but missing a small step can be important for these patients' longevity as well. So the Royal College of Physicians says a drop in systolic blood pressure more than 20 is important for diagnosis. Most of the patients about 85, when you check them once, they might not have postural drop, but when you check them twice in the same day, you pick up nearly 66% of them. The admission, the other important thing is we do have a lot of diabetics, around about 18 to 20%. These are elderly patients. We are, according to the guidelines, we don't need to have a strict sugar control on them. But when we looked at the data, when the sugar is less than 4, their mortality is pretty much 50% in the next 7 days, if it's not active upon. So one of the things which we need as a system to look at is somebody's hypoglycemic, especially in this age group, need to keep an eye on that. The other thing is the traffic light system works for the staff, green, yellow, and red. Green is they're deteriorating, something can happen. Yellow, they're not too well, they might get admitted. Red is why you're keeping them at home, or are you missing something? Majority of the time, one visit a day helps, and if the nurse or the therapist or the rehab technician or assistant or the consultant, whoever goes and sees the patient, they can make the choice if they want to increase the observations. With the yellow warning, it's at least minimum twice a day, but some patients might still be able to do everything and you can change it accordingly. The difficulty you face is you are doing everything when somebody comes into the hospital. Somebody just triggered a warning system, which means they need some kind of observations. Yes, we've done that. How do you know that the patient's deteriorating? Most of the times, elderly patients don't have the same temperature warning, same blood pressure warnings, but you can follow them up with a few things. These are the most common tests done. If they got COPD, a little bit of cough. If you got nurse prescribers, antibiotics. If they got CCF, then you can increase the furosemide. But the biggest thing is the safety net. They might get worse, but nobody's told them what to do next. And it always happens that they deteriorate quickly. So one of the biggest things which we find to help patients to keep them out of hospital is the rehab prevention. There's no rocket science here. Are they moving their bowels okay? You've given them antibiotics, they're not eating and drinking. Or if they got COPD, do they have oral thrush? Is that why they're not eating and drinking? They were mobilizing before, suddenly they're not. They might be in a residential or nursing home. What is the plans for that? Are you going to help them out of the family, or are you going to put in equipment? Pain control, you don't move around for a few hours over here, your back starts hurting. I mean, all the injuries from school and college comes up, so sometimes I need ibuprofen as well. They need the same thing. The other thing is patients, if you're elderly and frail and your physiology states you don't feel thirst, so you do need to monitor how they're going to drink. Simple measures which can cause them to be confused is, are they wearing the glasses or are they wearing the hearing aids? If they can answer most of these questions, this is the only measures here which is available to prevent delirium. It doesn't matter in American hospitals or in Japanese hospitals, that's all is needed. But this can be done at home as well, and these are measures which anybody can do as well. The difficulty is, if they don't improve, they need some kind of escalation. That is, either you call up your primary care physician, the consultants are part of the service, or an advanced nurse practitioner who can make a decision and go from there. But most of the time when locally, when we're looking at our data, we look at most of the patients, they go on from green back to white, which is normal, after a couple of days. Same thing with amber or yellow, they go back to a couple of days. When we get reds, we rarely get reds from greens progressing into amber. The clinicians make their decisions based on their intuition as well. We don't get the same parameters. If the patient's parameters are normal, the patient's not responsive, they need to get into the hospital to say why they've got hypoactivity or delirium of some kind. The difficulty is, you do get reds. The biggest aspect of reds is some patients might be known to the consultants with respiratory, or they could be palliative care, but not all the records have been updated yet. We've seen quite a bit of that. The patient's family know that they're not supposed to be transferred, but none of the other systems know. It's kind of nice to ask them out. If they got known COPD, there's a couple of things where patients refuse admission. You do need to know if they got a capacity to make that decision. There might be a hypoxia, but if you tell them you're going to die and you can get intravenous antibiotics for a couple of days and then we'll pull you out of the hospital, 99% of them make that decision to come out. What we are seeing lately is elderly, frail patients take that risk and say they're happy. They're done, they hear horror stories in the papers. They don't report 99.9% of the care in NHS services. They report the 0.1% in the newspapers as headlines. What do these elderly patients see? We can't fight that. That's their individual choice. If they got capacity, we can make that decision. The difficulty is, if the family are not involved, that causes trouble. So most of the case reports where we look at is if they're not involved, the family, and not documented, that's when the community clinicians get into trouble. But when you looked at the documentation and the explanation and taking the family on board, none of the case reports have ever proven to be against the clinician, or there's no cases won against the clinician. This is from the Litigation Authority or Risk Authority of NHS England. That's the latest report we got from them. In case when they're red, there are certain things which we need to do. And emergency clinicians and ambulance staff face this day in and day out. I'll let Ben talk about this.
Thanks. So this is about, everyone dies. It's inevitable that we're all going to die. Cheery topic, but it's true. And actually, we have to become very scared as a society about talking about that to patients. If you go to a nursing home, then you've got a 50% chance of being dead in a year. That was somebody with cancer. They have a really clear care plan. They talk about how you want to do all that sort of thing. It's inevitable that at old age we don't talk about it. So and people would like to choose how they act. Usually not in an A&E department with an F2 doctor sticking a can and going, I've done sepsis 6. No. It's not what people want for their death, and that's what we do quite often. So people with advanced dementia, bedbound for more than 3 months, non-communicative, not eating or drinking, advanced heart failure, well, maximum treatment. If we know these people are going to die, it should be discussed with patients. DNER is often in place. A DNER doesn't quite cover it sometimes. That means at the point your heart stops, we're not going to try and restart it. That means they still come into hospital, we still stick needles in, we still give them sepsis treatment, we still do all the other things, which are uncomfortable, even though we know they're going to die. Once they stop, well, they're dead now, I don't resuscitate them. Do all that undignified stuff prior to that point. The real thing we need to do around these patients with frontal frailty is talk about what their senior care is. What do they want? It's really important. Time and time again, our registrars will come to me and go, I've got this patient, I've done this, treat them for sepsis. What are they like? They're really frail, they're in a nursing home, they're bedbound. What do they want? I haven't asked them. Just treat them with painful invasive treatments. You don't ask them what they want. A lot of them, actually, if you ask them, I'll go back to the care home, I don't want to be in hospital, that's it, thank you very much. If they've got dementia, they go, I can't ask them they've got dementia. What's the most powerful question you can ask that patient's relative about whether they want treating or not? Particularly if they're bedbound in a nursing home, so they stop eating, drinking, it's invariably terminal within 8 months. What's the question we should ask the relative? Yeah, it's a good question, but that...
What's their wishes?
Patient's wishes, yes. It's about the quality of life. Patient's wishes, and often I don't know what their wishes are when you ever talk about it. Some will go, yes, they absolutely want it. Some will want it. So the best question I can ask them is never ask the relative what you want. I see people doing it all the time. What do you want? Ask them, it's not, legally it's not what the relative wants. Secondly, it's a huge pressure. I want my parents to live forever. I want also another thing, but I can't make that decision. It's not fair to ask them to do that. The most powerful question you can ask the patient is, if you're in a community with the patient, if they've got dementia, if they could rewind 20 years, be fully with it, and they were stood at the end of the bed looking at themselves now, what would they want? And it's nearly always invariably not to come into hospital to have antibiotics, to know that a month later they'll be back again with the same problem and they're going to die. That's the question we should be asking people. We ask them, what would they want if we can't be sure what they want, we can ask them, what do you think they would want? Ideally, it's not this. Well, I don't want to know, I want to spend a life in bed in hospital. If you ask that question in the right way, about a 99% success rate of getting people back into their home community, back to the care home, or just not treating them as people always have. Can't ask them that question. It's a really powerful question to ask. Please consider it. I'll pass it back to Bharath quickly.
The biggest risk everybody faces is, make that decision not to transfer the patient. You talk to the family members, family's wishes are known. And if you have an A&P or advanced nurse practitioner, you've got access to consultant, they can documenting what the patient's wishes were, what the family and the primary care physician. And it's clearly stated in that advance or escalation plan that they did not want resuscitation, but they also say that they don't want to be transferred. That is what we need to do for the patients. Around about 30% of the patients who came to A&E and died have already made their wishes known. That means they did not want to be transferred. Yes, this must be some junior staff in the residential nursing home who didn't have the support on the phone transferring the patient. It's not their fault, but also it can be made known if we can get into doing the right thing for them. It means a little bit of more training or also making their wishes known clearly. The staff who think that they're going to be safe, not safe because the patient, according to the news category, read they need to be transferred, it still doesn't count because the patient's wishes are very clear. And they got advanced features of COPD or CCF or dementia, or they're frail and they really don't want to get in there. That's the first time they want to go to hospital. They know that, but they really don't want to go.
Thanks. I suppose just to finish with that point is if we can have those conversations and document that stuff, we'll see far fewer people. And when I see people, when I talk that conversation in the ED, they often say they've been in twice in the last 3 months and no one's ever mentioned this to us, the relatives will often say, we're really scared of that discussion. I don't know why we are, if we have it. So I'm going to finish now, I'll talk for a while. I want to ask the same question we asked at the start. Please. I'm accountable for my decision, the actions, the outcomes, when I make a decision about a patient. I'll try and phrase it better this time. When I make a decision about a patient, I account for just that patient. The patient that is in my care, all the ward, the other wards outside the hospital, for every decision we make. Can I have a show of hands, please, for just that patient? 2, 72, thank you. Those under my care, those under my care. Those in my ward. Those in the other wards. And those outside the hospital door system. Thank you. And the other one, who holds the risk when older patients discharge, the fourth risk in discharge from ward or reading? Is it all the clinician? Most of the clinician? Equal? Couple of equal. Most of the patient? Got a few. And all the patient? Majority of the room. Thank you. So you definitely, there's been a shift within the room there of responses. And I suppose our ask to you is, thank you for listening, is if 2 gentlemen in their late 20s can talk to you about about this for an hour or so and potentially shift some of your perception on this. We don't know you, and actually if you can talk to your teams, talk to your colleagues, talk to your patients about this stuff, about where risk sits, where it is, if we discharge, if we move things around the system, we can change it. If we can get an NHS system that does the right thing for patients that they want, that has fewer people queuing outside EDs and ambulances, fewer decongestion in hospital, that will be a far better system we'll all be really proud of. So we really encourage you to do that and talk about that this afternoon. Thank you very much.